Thank you everyone for joining us at the NAMI conference this year. Today we have a presentation by Paul Rains and Seth Thomas called the Psychiatric Emergency, Changing the Culture in REDs. I hope you guys enjoy. If you have any questions or comments, feel free to leave them in the chat and we can address them after the presentation. Thank you so much.
And thank you, and welcome everyone. I'm Paul Rains, System Senior Vice President for Common Spirit Health for Behavioral Health, and today we have an enlightening presentation, hopefully for you, with regard to changing the culture on EDs. Dr. Thomas and I go back several years. We teamed up a little over a year ago to work on a pilot project for Common Spirit Health to go into our emergency departments to introduce some interventions and see what we could do to change the culture. We know for years our emergency departments have been inundated with behavioral health presentations, and oftentimes their staff is sometimes at a loss for exactly how to treat these folks, and feel like there are things that can be taught and learned, and workflows that can be changed to improve the experience overall for patients that present to our emergency departments. So I'm going to stop there, and Dr. Thomas.
Yeah, thank you, Paul, and good afternoon, everybody. It's a real pleasure to be here today. So I want to thank NAMI and Paul for reaching out and asking us to participate today. We hope that you find this presentation as empowering as I do every time I give it. By background, I am an emergency physician, so I'm an ER doctor. I was born and raised in California, and I still work here in the greater Sacramento region. And I am a director of quality and performance for our organization called Vituity. We are a national physician partnership, and we care for patients in the acute care continuum. I've taken a personal interest in behavioral health and trying to improve the care that we deliver to our patients in our EDs over the last several years. It's become a real passion of mine. So thanks again for having me, Paul. So the objectives today for our talk, and we hope what you get out of this, is that, first of all, you'll appreciate the growing demand and capacity mismatch in our ability to care for behavioral health patients in our emergency departments. So we're specifically focusing on the ED, not outpatient clinics or inpatient hospitals. But we want you to become also familiar with the existing gap in care that actually exists in our EDs. And I'll define what the gap in care is and then how we're going to address that. So we're going to teach you about emergency psychiatric intervention, or EPI for short, and its strategies that help us change culture and improve quality by closing the gap that exists in our EDs. And probably this is very familiar to many of you, especially if you have experience with working in an ED, or you know somebody that does, or maybe you've had a family or a friend that has gone through an emergency department with a behavioral health complaint. But over the last decade or so, we've seen an explosion in the demand that's placed upon our providers and our staff and our resources at our emergency departments when it comes to behavioral health patients and their presentations. So patients in crisis have been increasing significantly. In fact, it's not just adults, but it's children as well. So we've seen a 56% increase for children and over a 40% increase for adults. And not only that, not only the volume has increased, but we've also seen the proportion of emergency department visits that are made up of behavioral health complaints have increased as well from 2009 to 2015. And again, over the last 6 to 7 years, we've actually seen it increase even more. But not only that, but we've also seen an increase in length of stay associated with this particular patient population. So an over 30% increase in length of stay for mental health patients. And most alarmingly of all, the presentation specific to suicidal ideation or suicide attempts, intentional self-harm, have increased by over 400%. So very, very alarming. And what makes things worse and what makes matters worse is that accelerating to 2020, when COVID hit, this demand that's being placed upon our emergency departments has only increased. In fact, the CDC published in their Morbidity and Mortality Weekly Report that by late June, when they surveyed a group of just average Americans, they found that over 40% of US adults reported struggling with some aspect of mental health or substance use. And again, to be clear, this has nothing to do with patients that were primarily patients with previously diagnosed behavioral health problems, but this was just the general population. So if you look at this and you go, my God, over 40% of us are struggling with something, then what this tells me is that the demand is going to be increasing much more so in the next year or two. And that's okay, because we're here to help patients, right? And we're here to take care of them. But the way things currently function certainly isn't adequate. And that's what we want to address today and talk about how EPI can address it. So the current state in our emergency departments, if you have somebody that comes in crisis, is that unfortunately they don't receive very differentiated care. It's what we refer to as undifferentiated care. So when that patient presents in crisis to the emergency department, we end up placing them into a bucket. And let me kind of tell you, it's a proverbial bucket. It's not an actual bucket. But what I'm referring to is how we treat all patients when they come in. So if you're a patient that has chest pain, or you have the possibility of having a stroke, or you have an infection, the emergency physicians and staff immediately go, okay, we know that this is a potential heart attack or a stroke or infection, and we place you into those buckets because it allows us to sort of organize in our mind what we're going to do for you. And the unfortunate part is that although that works for most medical patients, when it comes to a behavioral health patient, if all we see is a psychiatric complaint, we immediately place them into a bucket. And the problem is after that, we don't further differentiate their care like we do with other patients. So if it's a chest pain patient, well, it may be a heart attack, but it also just may be anxiety, or it may be acid reflux. And if it's an infection, it may be something minor that can go home, or it may be something really serious that needs to be admitted. But with the psychiatric population, we actually don't know enough to do that. And so they're placed into one single bucket that is really undifferentiated. And unfortunately, the patient receives care that's inefficient because we're not trained to further differentiate their care and know how to care for them. And so what happens is we create this gap in care. And it's not something intentional, it's just something that happens. So from the left-hand side of the screen, from the time that the patient arrives in triage and is initially seen by a nurse and a provider, we get your vital signs and a chief complaint. We'll do a cursory medical screening exam. But beyond that, once we say, well, the likelihood that this is an underlying medical problem that's causing the patient's symptoms, really all care kind of stops at that point, because we don't know what else to do. We don't know how to provide healing. We don't know the correct medications. We can't get you effectively to the next level of care that's appropriate for you until somebody will come into our emergency department maybe and help us. That could be a psychiatrist, that could be a social worker, a crisis manager, a peer support specialist. And so those individuals with that special skill set help bail us out. But until then, we're dealing with what we refer to as a gap in care, unfortunately. And those patients that are feeling that gap in care, that are experiencing that, can experience that for minutes to hours to even days, unfortunately. So what we want to do is focus on a stopgap. And that's really what this program is all about, is to try to help bridge the two sides here, the emergency medicine side and the psychiatry side, so we can provide ongoing acute care for these patients and start the healing process quickly. But where does this gap come from? I think it's not enough to just recognize that it's there, but we need to understand where it comes from in order to help put together a solution and to close this gap in care. Well, there was actually a great article that was published a long time ago now, 2003, in Pediatric Emergency Care, where they surveyed 114 different emergency medicine residency training programs. So they wanted to ask how many of them actually gave formal education to their residents on psychiatric emergencies. And it's very unfortunate, but back then only about 20 to 24% of training programs actually gave any formal training with how to properly assess treat and disposition patients that were experiencing a psychiatric emergency or crisis. Now you may think, God, well, things must have gotten better, right? That was 2003, we're at 2020, but not necessarily. So this was a paper that was published in 2019. It was kind of a follow-up, and this was actually published in the Society for Academic Emergency Medicine, where they went to residents directly. And they said, well, it's not enough to talk to program directors, but we want to hear from emergency medicine residents. Are they actually getting any training on psychiatric emergencies? And so they had about 400 respondents, and unfortunately, things haven't gotten a lot better. So they represented about 15 programs, and unfortunately, under half of them had any formal training. And in fact, over 60% of the emergency medicine residents say that we are unprepared and we actually need more training. And only about 14% of residents said, yeah, we think we have enough to care for patients experiencing a psychiatric emergency. So really unfortunate. So what's missing in our education? Because I don't think it's just about physicians. I do think it's about nurses and everybody else that care for patients in our EDs. And what do we not know? Well, typically we don't understand how to risk stratify patients. We really don't know which patients are truly at risk for self-harm or truly at risk for harming others or, unfortunately being gravely disabled. So that's one area that we tend to not understand, and we don't end up delivering the appropriate treatment because of that. We also tend to overprocess patients because we don't have that baseline level of understanding. We tend to give patients a lot more than we probably need to, or hold on to them longer than maybe we need to as well, because we're lacking that underlying training. And unfortunately, we have no idea how to start the healing process. Is that most of us coming out of school, we don't have the knowledge on medications when they're indicated, on what to use. We also don't know how to treat patients like people, and we don't know how to de-escalate situations. We don't know how to form a therapeutic relationship, things like that that are all really, really, really key. So where do we go from here? Well, of course, Paul and I want to see us not to stay with this old-fashioned undifferentiated care. We actually want to provide more timely, differentiated care, give the patient exactly what they need, exactly when they need it to help them stabilize quickly and get them to the most appropriate level of care. So ideally, we would have the knowledge base and really the sense of understanding of what these patients need, because by really identifying what risk level they are, what they need, and actually can start forming that therapeutic relationship with them to provide that efficient care going forward. So that's really kind of our goal. How we get there, there's a number of different ways, but it really comes down to education and also focusing on the process in our EDs. And one area is to focus on split flow processing. And what that really means is kind of a fancy term to say that really low acuity patients that we have determined only need certain things should be separated from patients that are incredibly high acuity, very, very ill, that are in a significant crisis. And we should be able to assess them early on and give them what they need. We also need to sort of eliminate some of this over-processing and serial processing of patients that may not need all of these resources. But we need to further identify very early on during their stay in the emergency department who those patients are. And we're not very good at that right now. And we really need to focus on appropriate interventions and start them earlier, whether if that's medications, if that's indicated, then so be it. If it's getting a peer counselor involved or somebody to support them or engage the family earlier, we need to do that as well. And we need to be sensitive to those needs of those patients. So we do have a toolkit that we've developed over the last several years that we're very proud of. It has some of these evidence-based risk stratification tools. We even talk about medical clearance. De-escalation is a huge focus for us because most of us just have no idea how to appropriately de-escalate situations. Trauma-informed care, we're going to talk about that in a second because we really feel that that is foundational to the EPI approach. We have to start thinking about how we can put ourselves in the patient's shoes and understand from their perspective what's going on in their lives. We do have advanced medication algorithms that I'll also refer to later that we're very proud of. And then reassessment guidelines, disposition best practices to get patients safely to the most appropriate level of care. So we want to take a second and just talk a little bit about trauma-informed care. I hope most of you are familiar with it. And we're very proud that we've included that in our EPI approach, because it really starts with teaching our providers and our staff to not think about patients in terms of what's wrong with them, but what happened to them and how we can better understand that to come up with a care plan that is actually going to help them heal more quickly. And it's really all about kind of forming that therapeutic relationship with the patient. Paul, I know this is really important to you that we include this and that we've built this into EPI. Is that right?
Absolutely. Thank you, Seth. And you know, trauma-informed care, changing the perspective and the the perception, the attitudes and things, it's all foundational to changing the culture in the ED. Getting staff to understand that when a behavioral health patient comes into an emergency room in crisis, that is a real crisis for them. That is what they are experiencing, and in many ways, it is a trauma on a kind of a different level than say a medical trauma, but a trauma nonetheless. And understanding, as Dr. Thomas said, putting ourselves in the patient's shoes and understanding, they're coming in, their behavior, their reactions, all of that may be a little bit different than what they're used to dealing with on a, for medical traumas and things like that. But still, the understanding that taking a step back and understanding that they need to engage in maybe a different way with a level of empathy and understanding, and it's so very important for all these reasons listed here: the safety, trustworthiness and transparency, being able to engage effectively with a patient in the ED. Certainly peer support is something that we're seeing in some of our emergency departments, where they're working closely with, say, county behavioral health and inviting, even NAMI, I believe, has programs where they're now attempting to work with our hospitals and with our hospital EDs to provide these types of services. Collaboration between staff and clients, empowering our staff and our patients to be able to work together to achieve the outcomes. And then, humility and responsiveness. I don't know, I've got some stories I could tell you, and I probably will tell you a couple in areas where I've visited a number of our organization's emergency departments, and I've been in other emergency departments just as a consumer. And some of the things that, that I've encountered and seen, and I'm sure many of you probably have also, you overhear an encounter going on between a staff member, oftentimes it's a nurse, that's encountering a patient. And whenever I've seen or heard those types of interactions take place with patients that obviously are struggling with behavioral health issues, oftentimes the nurse's reaction is, just do what I tell you, or we'll be back with you, shortly. And for a person that's experiencing a behavioral health trauma, shortly can seem like, an hour can seem like 10. Certainly when they're sitting there for, 4, 5, 6 hours, that does not bode well for that patient's recovery. And so we see interactions going on where it's obvious there's kind of a lack of not only understanding but education on how to interact and how to dialogue. And part of that, certainly plays into the verbal de-escalation skills, things of that nature. It's difficult to even think about or want to engage in a different way if we don't provide some level of understanding as to why a person may be behaving in the way they have, needs that they need to have met, and that we need to figure out and find out what are those needs and how best can we meet them, rather than directing or trying to have the patient follow a plan of care that we think is best for them. In these particular cases, in working with this population, we realize that through a trauma-informed care approach, we are working with them, not trying to guide them or tell them what it is that they need to do. That we need to be collaborating with them to determine what it is that they need, and that we try to provide that as much as possible. I think oftentimes it's a matter of, the split flow processing that Dr. Thomas mentioned, is that when we just let them sit there and languish, doesn't do anybody any good. Our staff, them, their families, and you know, caregivers. But when we pay attention to and provide for their, you know, for their needs and try to help them get to the right level of care, whether that's, you know, inpatient hospitalization or services in the community, that we've taken a genuine interest in helping them find the level of care and help that they need. So I think it's a lot of part of our dialogue and conversations with the staff that we work with in the EDs, and it's very important that they understand that changing the culture really needs to start with changing kind of their attitudes toward how they perceive and deal with this population.
I completely agree. And I'm so glad that you told that story, Paul, because again, this is not a skill set that any of us come out of school with, and we have to be exposed to it. We actually have to have somebody teach us and show us and demonstrate how it's done to better appreciate it. And I can almost think back to, you know, in my career, I've been working now for almost 11 years out of residency. And I can almost remember the moment at which somebody kind of flipped the light switch on in my head about trauma-informed care and de-escalation and partnering with these patients. And it was one of the most rewarding things I've ever gone through in my career. Honestly, I can honestly say that. And I didn't go into this specialty you know, specifically to try to take care of behavioral health patients, but now I realize the power that we have and how we can really impact this patient population. So I was really proud of it too. So thank you for emphasizing that. And with respect to how we approach patients, it's definitely about trauma-informed care, verbal de-escalation, kind of the softer side of what we do. But I also think that what's important here is how we use the tools we have available to us. And one of those tools would be our medications. And although medications aren't always indicated, aren't always helpful, sometimes they can be. And when indicated, we have to be thoughtful about how we deliver the medications and which medications we use. And unfortunately, going through our training, kind of going back to those two slides where I demonstrated that we just don't get a lot of that exposure in our residency programs. We're really taught to only use one or two different medications that are heavily sedating. One of those is referred to as haloperidol, also known as Haldol. And I don't want to make Haldol out to be a horrible medication. In fact, it's a great medication for certain specific reasons. And I'm not a psychiatrist, so I can't tell you the exact reasons that we would be using it, particularly as an outpatient. But I will tell you that it's overused in the emergency department, particularly via intramuscular or injection routes. And there is a dark side to that. And we have to start thinking about using medications differently and actually considering using different medications that have less side effects, that are less sedating, less reactions, that patients tolerate better, that experts in the field say are probably superior medications. You know, using haloperidol and looking at how often we use it, we're actually causing an increased length of stay in the emergency department. There are increased cardiac risks, and it's a kind of amazing, but it's actually not FDA approved for agitation. And this all came directly from a small research article that Dr. Zeller, one of our, he's our vice president of psychiatry at Vituity, put together. And I thought it was just great. And once you actually start to read the evidence and the rationale behind it, you go, we need to think differently about how we're doing things. But all it really requires is a little bit of education, and people start to change. They realize that, boy, doing things the way that we were taught you know, is not necessarily the right way to do them in the future. So what we start to do with EPI is we start to address all these gaps in care, the gaps in our knowledge base, and we start to put a process into place that we start treating these patients exactly like we would treat anybody else coming into the emergency department. We start assessing them immediately, better understanding their risk factors. We provide that medical clearance and screening exam right up front. But we also start the healing and the treatment process. We try to move them to an area of the emergency department that's, you know, less loud and less agitating, right? Less annoying. And then we start their disposition planning very, very early. So rather than waiting 6, 8, 12 hours, 24 hours to better understand what we need to do for this patient, we're doing it right off the bat. And so it's a collaborative team approach, and that's what we're really trying to get us to do. We also use other evidence-based tools like our risk stratification matrix, just so that we can, again, think about patients from a trauma-informed standpoint and apply predictive risk models to them, so we better understand who's truly at risk, who truly needs, this kind of level of care or this approach, who needs resources, who needs this and that. And so it really helps us differentiate in our minds how we can better care for these patients. And again, none of this exists in our current training program. So we kind of had to develop it along the way by talking to experts and patients and this and that in our field. We also use other tools to help us communicate. This is something that we didn't come up with. It's the Behavioral Activity Rating Scale, which just gives us a way of communicating so that we can pick up on levels of agitation or patients that just aren't doing as well as we had hoped very, very early. And the purpose of doing this is so that we can intervene and help support the patients, as opposed to just waiting until everybody's at a crisis state where patients need to be put into restraints and given intramuscular injections. None of us want to do that. In fact, we're trying to minimize that. And so this is a tool that just helps us identify patients that are starting to escalate or a problem is developing, and so that staff can communicate more appropriately. It's just really kind of neat application of these things. So, Paul and I have been working on this for a couple of years now, and we did have some pilot work that we had done a while ago in Chicago, and I wanted to share a little bit of that. So how does this actually work? Well, it's really exciting because, again, when we approach emergency department providers and staff with all of these principles, it's almost like going into this, a fresh flower bed, right? Very fertile soil. There's like nothing growing there. And then we give them these pearls of wisdom, these little seeds of wisdom, right? And hey, there's a great way of doing this. Think about doing it this way. And as soon as you start giving them information, they grow and they start to blossom, and you can see the culture change immediately. And so here's just an example of some of the things that we tracked. We're very objective in this, where we said, hey, let's start to decrease the use of haloperidol. Let's start being more thoughtful about the medications that we want to use when appropriate. And let's work with the patients to identify who needs them and what they want. And as soon as we started kind of giving them that education, the prescribing patterns changed it seems like almost overnight. And they started giving great feedback on how well it was working. So not only was it done at one site, it was done at multiple sites. And we saw the same results over and over and over. The prescribing patterns changed. Everybody got happier. They started to really like the approach. But it wasn't just about medications. It was about how we treat the patients as a whole person. And it was about who we involve at what point in time and what kind of testing we do on them and how we can actually work on hardwiring some better disposition practices, right, and resources for these patients. And as soon as you start doing that, it's amazing when we focus on this population, the length of stay started decreasing. And it was great because we said, well, gosh, are we decreasing the length of stay so much that there are going to be bad outcomes? And we actually saw none. There were no unexpected bounce backs or bad outcomes or anything. It was actually just, everybody was positive about it. So it happened over and over, whether it was a low risk population, moderate risk population that needed, additional consultation. We found that they all spent less time in the emergency department. So this was really, really encouraging for us to see. And I think for us, and I'm going to ask Paul here in a second to comment on this, but for us, one of the things I was very proud of was that we saw a reduction in the use of restraints. And this, to me, was a major improvement in outcomes, because it really told us not only are we getting patients through a very complex, dangerous system quicker, or more quickly, I should say, and being more thoughtful of how we treat these patients, but we're actually not putting them in restraints. We're actually forming a better, more therapeutic alliance with these people. So I was very proud of this. I don't know if, Paul, you had the same feeling?
Oh, absolutely. Anytime we can reduce the hands-on interventions. I've taught crisis de-escalation in the past in several different facilities, and one of the things that's hard for me to get my mind around is how you know, when patients are encountered that seem to be behavioral issues, that, you know, the typical response is, well, we've got a solution for you. We're going to, you know, provide you with IM medications, and if you really don't behave, we're going to, you know, we're going to strap you down. And my, you know, my point in the training many times is, you know, consider how much time and effort and resources, staff resources it takes to go there. Wouldn't you rather head these things off before they ever happen? You know, and seeing a reduction, also the, you know, the perception of working in a safe environment. Too many times in EDs, you know, the perception is a behavioral health patient's here, you know, look out, you know, they might flip on you and become violent. And it's just, nothing could be further from the truth. It's somebody, you know, a human being that's walking into a place of service and care that's in a situation where they need help and they want help, or they wouldn't be there. Sometimes they're not there, you know, they are there against their will. And, you know, but still, the fact remains that it's all in how we approach and treat these as human beings, as people, okay, with needs, and not get to that place where, you know, the mentality is we'll shoot you up and tie you down. That's just not how we want to do business like
Yeah,
that. So
I agree. And Paul, I think it's interesting because there's this, I think it's a common misperception or misconception, I should say, about the fact that some really truly believe that by using these heavily sedating medications and restraining people, that it's actually keeping us all safer.
mm-hmm.
And I don't know how you feel about that, but I actually think it's quite the opposite. Most injuries that occur for not only patients but staff are when we go to administer these medications and put people into restraints. That's when injuries actually occur.
And we've actually traumatized the patient, re-traumatized the patient when that happens. We talk about trauma-informed care. Patients don't come to our, seek services, come to our emergency departments or really anywhere and expect to be traumatized or treated in that way. Sometimes, you know, we clearly understand, I've been working in mental health for over 30 years, and I clearly understand there are times when there is behavior that is difficult for a patient to control, to maintain their own behavior, and they need the assistance at the lowest level of intervention possible. And that's where we really need to get to, is that it is possible to have a good outcome without necessarily escalating a situation to knock them out and, you know, tie them down. That's just not. We have got to eliminate that mentality,
Yep.
especially in our EDs.
Yep, absolutely. I agree. In fact, I'll tell a quick story. I once had a patient, this was probably about 7 or 8 years ago, and I came into my shift in our ED, and the staff came up to me and said, you know, there's this woman in the back, and she's on an involuntary hold in California. That's a 5150 for danger to self, but she's agitated. She's been here for several days. And I'm like, how many days? And she was here for, I think it was like 5 days or something in our ER. I couldn't believe that she had stayed that long. And she's complaining of some chest pain and this and that. And I said, oh, okay, well, why don't we get an EKG and, like, let's take a look at her and make sure there's nothing cardiac going on and everything. And, you know, she had a little bit of an elevated heart rate and things like that. And, but she had been restrained multiple times and had received multiple doses of heavy sedating medications, antipsychotics like Haldol. And anyway, their EKG looked fine. But when I went to assess the patient, I realized that something else was going on. And we ended up causing her to have a deep vein thrombosis, a blood clot in her leg. And she ended up having a pulmonary embolism, a life-threatening medical condition. And I know you could argue, gosh, did she come in with it, this and that, or did we cause it? And I think my concern is that we probably caused it. This was probably something that, you know, just by probably overutilizing this approach that you're referring to, Paul, probably causes a lot more harm than good. So anyway, a worthwhile conversation, but this was something we were incredibly proud to see occur through our efforts, through our EPI efforts. But not only that, this wasn't just about how we were treating the patients and their length of stay and this and that, but we wanted to know what the staff thought too, because it's important that that we get feedback from everybody involved in the process. And so we ended up surveying them and asking, do you feel safer? Do you feel like you're using less restraints? Do you feel like the quality of care is improving? Please let us know. And generally they felt safer. There were some that disagreed with that. What I found that was really made us feel very good about this is that not only did we have objective criteria to demonstrate that the restraint utilization was going down, but they subjectively felt like they were putting patients in less restraints. They felt like they had a better relationship with their patients. And overall, the quality of care was improved. And so they felt like they finally had some knowledge, they had some tools to use to help care for these patients as the real patients and the human beings that they are. So that was really great for us. So we said, Paul, let's go ahead and do this again and see if it's something we can repeat. And so I'll let you talk a little bit about our program.
So when we kicked this off, we identified 9 different hospital emergency departments within Common Spirit, within Dignity Health, actually, in California and Nevada, and we laid out a kind of a menu of goals, interventions, and we asked the leadership of these hospitals to do some self-assessment on what were their perceptions on their quality of care in their emergency department for behavioral health patients, as well as how ready did they think they were to implement these interventions. So we approached them. We had those 9 hospitals, the medical leadership, the nursing leadership, the social work folks. I mean, all the right treatment team people that treat patients in REDs. We pulled them together, and we had a kickoff meeting in the Vituity, one of the Vituity offices in Emeryville, California, and we sat down and they were able to pick from the strategies. So if they felt like it was the risk stratification, the split flow processing, the reduction of over processing, early and appropriate treatment, and those include sub interventions, each of those, and then the de-escalation. As it turned out, many of them chose interventions that were relatively similar. They all wanted to see what the changes in medication. They all received some level of de-escalation training and reduction of split flow over processing. So kind of in a way, many of these interventions were kind of across the board for all these EDs, but they focused on 1 or 2 that they felt were things that they could improve more so. So it was a 6-month program. We started in August of 2019 and wrapped it up and had a wrap-up event in January. The kickoff event, as I said, you see in these photographs where we had these work teams, these hospitals come together and talk about what it is that they felt like they wanted to develop as far as an action plan. During the course of the 6 months, we had monthly or even more frequently coaching calls. And we also committed to coming on site to each one of the hospitals for one of those coaching events and spending some time in the ED, looking at what it is that they're, the environment of care that they have, as well as just to kind of show that we're, being supportive and showing up. So we were actually able to make it to all 9 of the hospitals during those 6 months and spend a day with each one of them. And then we had the wrap-up event where we got back together and talked about the outcomes and what their experience was like. And it was absolutely amazing. The kickoff event was kind of like, I look around the room and I could see the looks on the faces like, what are we doing here? At the wrap-up event, it was like, wow, we had no idea that we could affect a change as significant as that. So.
Yeah, it was really empowering. And I think the beautiful part of this is that it's effective if you go into one emergency department and teach them these techniques and tools and give them the tools. But I think it's much more powerful if you bring groups of EDs together, because they could learn from one another. And like you said, Paul, there was something about, we almost hit critical mass, I think, where you had enough people in the room that started kind of light bulbs started turning on, that it really empowered the group to go out and do great things. And some of those great things I'm going to share with you right now. So again, a lot of the sites were focusing on how they approached medications, because again, I hate to use the word neglect, but I feel like sometimes we neglect these individuals in our departments. And so we said, let's actually take an objective approach here and see what we're doing with them. So not all patients require medications and are not all appropriate, but when we do, let's make sure that we're doing it in a timely fashion. And let's not forget that these patients also have medical comorbidities, and we should be stabilizing their medical conditions as well, because oftentimes we just think, oh, they're in psychiatric crisis, but no, they actually have diabetes and high blood pressure and other things that like everybody else does. And so let's treat them like people and patients. And so you can see when we started tracking them over time, it went from patients waiting hours and hours and hours to receive anything, that can even just be like a Tylenol for a headache, down to a much more appropriate time frame where they're actually getting care in real time, getting what they need right away. And we also found that, again, the same pattern existed where before and after we gave them the information about which medications are appropriate and which ones are safe to use in which cases, they immediately started changing their patterns, and they started actually talking to the patient and coming up with a plan with the patient and forming that therapeutic alliance. It was beautiful to see happen, and these numbers just continued to improve. So that was really very, very empowering for me to see. And we saw the same thing early on as well, where restraint utilization started going down as well. We know that for some of the other sites, they're seeing even lower numbers now, which is great. And I know, talking to Scott Zeller, our Vice President of Acute Psychiatry in Vituity, he used to help run John George Psychiatric Facility in Oakland, and he said that they got so good at verbally de-escalating patients and trauma-informed care that it would be almost like 1 in 1,000 patients would ever be placed into restraints, which is an amazing thing. And so my hope is that we end up getting to that point where we're not just seeing a few times a month, but we're actually seeing once every few months or something like that. I think that would be amazing. So we're definitely a lot of progress. We also saw, despite similar volumes, we saw decreases in length of stay as well, which to me indicates that we're just not ignoring these patients. We're actually doing something with them. We're trying to get them to the most appropriate level of care for their symptoms. So it made a lot of sense. It seemed to work. And the providers and staff alike really thought that it was very, very effective. And so, Paul, I know you like to talk a little bit about their perceptions in our second case study.
Yeah, when we did the wrap up, we were looking for outcomes measures, and some of those were qualitative. So what was the attitude prior? And at one particular table, I was asking in the beginning kind of what was their perspective on their current practice, and these were some of the things that we heard from one particular provider, that the B52, the Haldol and Ativan, the 5 of Haldol and 2 of Ativan, they felt like it kept them safe, and that I'm an ER provider, I'm not treating this long term. So the attitude that they should just be in and out, I guess they should feel lucky that we're doing what we're doing for them. And do psych patients actually care what meds they get? One of the things that in some work that I was doing in some of our EDs, when I asked, how they get to their medication reconciliation, the response that I got was kind of shocking. Is we don't do medication reconciliation, and that means that they don't try to find out what medications the patient has been on, and that that can be dangerous. They could be on other, like Dr. Thomas said, other medications that they need. I actually encountered a patient that had been knocked out for about 24 hours, and when he woke up, he was rather agitated. I went in and spoke to him, and I said, what's going on? He indicated that he had anti-seizure medication that he took on a regular basis, and he was not getting that, and no one had even asked him about it. So just an example of where, yes, they care what meds they get. They absolutely care what meds they get. And then after this was done, that same physician, these were some of the responses that we heard. It worked better than I thought it would. Another said, I was surprised how well it worked, and the patient seemed happier. So obviously they were experiencing the outcomes of this being far more positive than I think they had anticipated.
Yeah, it was amazing. Thanks, Paul. It was like amazing. I think it was one of the ER physicians. I remember this distinctly. You probably remember him too, standing up. It was almost like a confession.
Yeah.
At the wrap up. I can't believe I felt this way before. And now looking back on it, I'm a changed person. You know, it was quite amazing. And so we even did some surveying, right? And got some results on the surveys.
Yep. So I think the starting the meds thing was just huge. Paying attention to that one factor, finding out what medications they were on, and starting them on meds or any meds being offered, feeling safe to take care of patients. That was an increase of 34%. And then the subjective use of restraints, the reported to be, down 82%. So all in all, good for the patients, good for the staff, good outcomes all the way around with these interventions.
Yeah, yeah, and it's important that, like we said earlier, to ask the staff, because this truly is a collaborative approach, and we can't do it without any one single person. And I should clarify that in the kickoff events, although we brought multiple emergency departments together, we really expected them to have a multidisciplinary team there. So physicians were represented, advanced providers and APPs were represented, nurses were represented. We had several case managers and social workers come. We had psychiatry. We really had everybody there to help us design these interventions for the emergency departments. And that, I think, is what made it highly successful as well.
Yeah, and I know some of you may be asking, why didn't we do a patient satisfaction? We talked about that. Just the logistics of it was something. I mean, we certainly realize that going forward, that is something we want to be able to address. But in this particular pilot, we were not able to, for logistical reasons, do that.
Yeah, that's actually one of our future goals, is to be able to do that and ask patients and family what their experience was. So I think looking back on it, I can't imagine it could have gone a lot better. We had a significant reduced length of stay despite similar volume, which to me, as an ER doctor, actually does mean quality of care, because the longer patients wait for care, they decompensate. And I don't care if you've got a heart attack, a stroke, an infection, sepsis, or a behavioral health crisis, you get worse if we ignore you. We definitely saw improved quality of care and experience overall. And I think that was evidenced by several of the outcome measures that we measured. We definitely achieved improved culture, as evidenced by surveys, as well as some of the comments directly from our, some of the providers that probably didn't want to change at all, some of the naysayers at the outset. We saw improved safety by decreasing the restraint utilization, and of course reduced resource utilization, which is important too. So use the appropriate resource for the appropriate patient's needs. And so where we're going from here, well, Paul, what do you think? Where do we need to go with this program?
We definitely want to accelerate implementation. I know there's a second level pilot that's going on that Vituity is conducting, and Common Spirit Health is also looking at where, what other hospitals we can get this into. Certainly that surveying, interviewing the patient, doing a patient satisfaction survey, and incorporating all the feedback from both the staff and the patients to continue to improve these interventions. I've sat at tables, work group tables with ED staffs, hospital executives and things for years, looking for answers to these questions. And one of the things that I became convinced of over that period of time is that there are a number of people working in the field that have the answers and have the solutions. The ED folks just are too busy to really get down to implementing them. So, picking up the ball and running with it and having someone come in and assist with this, I think, has always been kind of the key to making this type of thing work. And it's exactly what we did. And I think what we're seeing is exactly the results that we wanted to see, is that we work in collaboration with these staff to help them achieve these outcomes and goals that are good for everybody. And all in all, the result was positive. So
I agree, Paul. And I think these are great next steps. I can't wait to work with you more and other sites. I really want to get the word out there that this works. And I think the message to all of you in conclusion is, really our emergency departments aren't bad places. I think the emergency department staff and providers aren't bad people. It's just, I've come to realize that we don't know how to take care of every patient population, despite the fact that we think we do. And so just giving us a little bit of information, showing us that there's a better way, can clearly change our culture, can clearly change the way that we care for patients and lead to better outcomes. And that's why we're all in this. Well, thank you all so much. I think that concludes our slide presentation, and there's our contact information. If for those of you that want more information or want to better understand how you can help us with our cause. But I think Paul would be happy to take any questions if there are any.
Back over to our host and
Thank you so much,
facilitator.
gentlemen. I am looking through the chat now. I did have one question from Denise Piper. She just joined in the middle. She was wondering, what is an EPI?
Oh yeah, that's a great question. Sorry for that. We defined it pretty early on. It's emergency psychiatric intervention is what we're calling it. So it's really this number of different strategies that we employ to help our emergency departments care for behavioral health patients better. And it really involves just a basic understanding of what a behavioral health crisis is, understanding how to better assess patients, how to treat them, how to start the healing process earlier, how to appropriately use medications and when they're indicated, and then how to, of course, measure success. But I think it really is a sort of a summary statement of our approach. So thank you for the question.
Awesome. We do have another question from Huva. Is it true that diagnosis is required prior to receiving Medicaid? Does that keep trauma from being diagnosed? It's not officially a mental illness.
Paul, you may have a better understanding of the reimbursement part of that.
Okay, yeah, and I'm a clinical nurse specialist by training. I don't know that there's a requirement for diagnosis. The thing about, at least the way I was taught, the behavioral health psychiatric diagnoses are not something you can just diagnose in one encounter. It's something that requires information on history and then watching symptoms over a period of time to verify and validate. Certainly with enough collateral information and information from the patient and caregivers, sometimes you can come up with what's called a provisional diagnosis. But I don't know that that's certainly that is something that if a patient is being treated or by a provider or practitioner, a provisional diagnosis is usually given. Oftentimes we provide a kind of a provisional diagnosis when we evaluate a patient if they're coming to an inpatient setting, and that generally is kind of a blanket diagnosis that based on the symptoms. I mean, just kind of differentiating: is it depression? Is it? I think one of the most difficult diagnoses to really pin down is psychosis, because of all the different etiologies for that. So is it substance induced? Is it mania? Is it something on the schizophrenic spectrum? So, but to my knowledge, having to have a diagnosis to be treated or for that reimbursement to happen, there has to be something entered there, yes, for purposes of treatment. But again, I mean, that diagnosis can change over time, and I think it's one of the pitfalls of behavioral health medicine is that oftentimes we don't do I think a good enough job of really pinning it down and taking our time with it. And I think that's something I've seen diagnoses change over a period of months and years with certain folks, depending on their presentation of their symptoms over that period of time.
Absolutely, yeah, thank you, and also to further clarify Paul's statement, in the ER, we don't care what your ability to pay is. I mean, you come in crisis, we're not going to ask for reimbursement first. We're going to ask how we can help first, and we should be initiating treatment regardless of that. I know there are a couple other questions here. I'm gonna thank you for reminding me to look at the chat. I'm gonna actually answer Alan's question in just a second because Alan's got a great thought. I'm gonna just address Susan Johnson. Susan, thank you so much for that comment. Absolutely, that is absolutely degrading. I completely agree. So she said, twice my son went to an emergency room on a 5150. When he was transferred to a psych hospital, he was sent in a gown and his street clothes were not sent. How degrading. Do you address respect for privacy? Absolutely. We've got a long ways to go with that, and we do. And of course, we're also trying to address how patients are treated with dignity when they come into our ERs. And the fact, unfortunately, that a lot of our patients are still stripped of all possessions and placed into gowns that identify them as behavioral health patients, I personally don't like, and I think that we should start to kind of think about this a little bit differently in how we approach this, particularly as it relates to their level of risk. And so thank you for bringing that up. I think it's an incredibly important point, and we could always do better with this. So I will take that back and also ensure that our sites are implementing a way to better respect the patient's privacy. So thank you so much. Paul, do you have any thoughts on that too? I think it's an important point.
Absolutely. We being advocates for patients and working with our emergency departments is extremely important for the provider, the behavioral health provider community. Is that we clearly understand that things don't always go right, and we need to work toward making that better. To me, it's unconscionable that we would treat anyone like that. And frankly, what's really amazing is that patient belongings is one of the top complaints that we have in behavioral health is keeping up, and partially because of the way oftentimes patients are transferred more often than not, more so than they would be in a medical facility where they could go from an ED up to a medical bed in the same hospital. Certainly there's less opportunity to lose their stuff, but oftentimes when patients are transferred from an ED to another hospital outside, there's just logistics of making sure that everybody is coordinating the work so that things don't get lost. It's not okay.
Yeah.
And there's another question in here about consumer advanced directives.
Yeah. I want to address that too.
We're legally obligated to follow that. The psychiatric advanced directives, I don't think it's all that well known that it's in statute in California that we are required to honor that within reason. I mean, it's certainly something, but patients have the right. I think oftentimes what's difficult is, especially in an ED setting, is access to that kind of documentation. But if it is already in the patient record, it certainly needs to be recognized and honored. Right?
I think it's a big opportunity too. So I'm glad, Alan, that you raised that. Is that oftentimes when patients come in that are incapacitated or are in such crisis that they can't communicate appropriately, we actually do already have certain documents that are called care plans or plans of care in our emergency department for patients that we know, how we should approach them and treat them. That being said, I think there's a huge opportunity for us to work with this patient population to include psychiatric advanced directives as a component of these plans of care. So after the crisis is over, let's talk to the patient. What do they want? How do we better assess them and treat them in the future? Just the whole thing that we're going back to which medications, did we use a medication that caused something that caused a side effect or an adverse reaction or something like that? Or who do you want us to reach out to when you have a crisis? I mean, there's just a huge opportunity. So I thank you for raising that as well, because even though we recognize the need, and as Paul alluded to, that there's actually state statute about that, I think we could do a much better job of utilizing them and bringing them into our plans of care. So thank you so much. And then do we work with forensic patients? And I'll say personally, I don't, and our emergency departments don't, but I don't see why this EPI approach, emergency psychiatric intervention, couldn't be applied in almost every setting. I don't know, Paul, if you have experience with the forensic population?
Not much, but I agree with you that it can be applied in any setting. I think that especially in forensics, that's another area, a topic for another day, working with law enforcement, our corrections and things around how to manage this population. There's certainly a lot of opportunity there as well to better the environment and the experience.
Yeah. And I also think something you said earlier, and when we were discussing trauma-informed care, was sort of this emerging opportunity to bring in peer support specialists. And we've seen that. We've actually used them a couple of times, and that can be incredibly powerful to help us communicate and connect with the patient at their level, so that we have a much better understanding of really what's driving their presentation and how we can help stabilize them. So all really great thoughts. And again, I really appreciate you for the feedback, and especially Susan about the privacy issue. So thank you so much.
I do have one more comment about the advanced directives. One of the things that I find extremely helpful is when we know what works with someone, because if they're coming in crisis oftentimes and they're not able to communicate effectively with us, if we had something in writing that says, when I get, when my symptoms get exacerbated and my behavior becomes such that we can't interact effectively, here's what works with me, that kind of information is so valuable and
invaluable.
For us to not have to go to, shooting up with IM medications and restraints. It's so helpful to have that information ahead of, when it's needed.
Well, all right, gentlemen, we are coming to the end of our session. We have about a minute left. I'm going to go ahead and compile all the rest of the questions that we've missed and see if you guys can follow up with our participants after. I appreciate you guys taking the time to sit in and show your findings. We appreciate your hard work, and thank you so much for coming to the NAMI conference.
Thank you. It's been an honor to be here. Thank you so much.
Appreciate it.